All right, hello everyone, and welcome to another round of our Health Reform Beyond the Basics webinar series. Thank you for joining us today. For those of you who are new to our webinar series, this is a project of the Center on Budget and Policy Priorities, which is a nonprofit policy think tank in Washington, D.C. This series is designed to help advocates, assisters, state and local officials, and others assist people in accessing and understanding the Affordable Care Act's health coverage options. It is intended for those working on the implementation of health reform and is not intended for press purposes. Today's webinar, the third in a four-part series on key elements of eligibility and enrollment, will provide an overview of health plan design, including cost-sharing charges in marketplace plans, eligibility for cost-sharing reductions, and how cost-sharing reductions affect costs for consumers. And it will go over how to evaluate marketplace plans based on cost-sharing and plan design. So to guide us through today's topic, please welcome Sarah Leek, a senior policy analyst here at the Center on Budget, and Hallie Cloud, our health outreach manager, also here at the Center on Budget. And with that, I'll turn it over to Sarah to get us started today.
Thanks, Kyle. Hi, everybody. Really happy to be talking with you about this today. So before the first part of this presentation, even though we're doing a Beyond the Basics presentation, is sort of basic for a lot of you, but we want to make sure that everybody has the basic building blocks and understands kind of what goes into these different plans that you're going to be seeing on the marketplaces. So just to review, important aspect of plans is the premium, right? The monthly cost that a person pays for the plan. And another important aspect of the plan from the consumer's perspective is the cost sharing charges. And these are the cost sharing charges are the things that the person pays out of pocket when they use a healthcare service under their plan. And then the different components of the plans that we're going to be talking more about today are the covered benefits. That's in this case, the essential health benefits under the federal law, which includes preventive services. Additional benefits may be covered under people's plans. And then there's also the provider network, which refers to the fact that insurers contract with physicians, hospitals, and other healthcare providers to provide services to the people enrolled in their plans. The provider network can be broad, meaning that it has a larger number of providers, or it can be narrow. And a plan may be covering providers outside of its network, or it may only cover providers within its network. So to review the essential health benefits, you can see here the 10 different kind of categories that are part of the essential health benefits definition. These are the benefits that all qualified health plans have to provide, those in the marketplace, in the individual marketplace. That includes emergency services, hospital care, lab services, prescription drugs, hospitalization, mental health, and substance abuse services, as you can see here. And then the cost sharing charges that people will see when they use the covered benefits under their plan. Some of the major terms to know are deductible, co-payment, and co-insurance. And you can see the definitions here. The deductible is the amount the enrollee has to pay before their plan begins to pay for most benefits. It's usually a relatively large amount for folks in marketplace plans, and it's set on a yearly basis. There's co-payments, which are a dollar amount, like a $5 that you have to pay when you go to get a prescription, or the $25 you might pay when you go to the doctor. That's just a flat dollar amount that you pay when you get an item or service covered under your plan. And in many cases, what you'll see in plan designs is that co-payments are applicable before the deductible is met, meaning that people don't have to pay the relatively large deductible first. In many cases, they may be able to get some of the common services they may use using only a co-payment. And then the co-insurance is when there's a percentage of the cost for an item or service that an enrollee must pay. So an example of that would be if a person has to pay 25% of the cost of a lab a visit that they have to have, or 50% of the cost of a specialty drug. Those are the sorts of percentages you might see that are co-insurance percentages. Another important element of marketplace plans is the maximum out-of-pocket limit. You sometimes see that abbreviation OOP. This puts a cap on what an enrollee pays in cost-sharing charges each year. So it does apply for the entire year, and it applies to in-network services and not out-of-network care in most cases. The out-of-pocket limit is not the amount that an enrollee has to spend each year, it's the maximum amount that they're going to pay in deductibles, co-payments, co-insurance under their plan for covered services. So in 2018, the maximum out-of-pocket limit under federal rules that can apply to an individual is $7,350 a year. And then for a family, the plan out-of-pocket limit could be $14,700 for an entire family that's enrolled in a plan together. But that $7,350 that you see for individuals does apply to each individual in a family as well. So that's an important protection, particularly for people with very high cost health needs. And then for lower income people who are eligible for cost sharing reductions, which we're going to talk about a little bit more in a bit, there are lower out-of-pocket limits that are established at the various income levels that you can see at the bottom of the slide. So that's more protection for folks who are at the lower end of the income scale. A couple of other important things to know about cost sharing charges are that some services may be exempt from the deductible, meaning that that's sometimes called first dollar coverage. An example of that might be if a plan covers 2 doctor visits for a co-payment and then has a different cost sharing structure for other physician visits, or if a plan covers generic drugs at a co-payment and doesn't make you pay the deductible first. That's an example of the insurance plan trying to kind of give people relatively lower cost access to some of the common services that they may be most likely to use during the year. Another thing to be aware of is that some benefits may have a separate deductible amount. So there may be sort of an overall plan deductible. Let's say it's $2,000 for most services. But then prescription drugs, which is something that are relatively common need for people, that may have a separate deductible, say $500. That's less. So it's intended to give people easier access to prescription drugs in that example during the year. So cost sharing and metal tiers, I think many people are very familiar with the fact that there are bronze, silver, gold plans in the marketplaces, as well as catastrophic coverage, but they may not really know what that means. So we just wanted to explain that, there is a term, actuarial value. It's a very technical term that's used in the insurance industry, but for purposes of setting these metal levels, what it is it's a measure of the percentage of expected healthcare costs a health plan will cover. It's a general kind of summary measure of how generous a health plan is, and it's calculated based on the average for an overall population and doesn't necessarily reflect the actual cost sharing experience of an individual. So in simpler terms, I think what you would most likely want to know is that if you have a bronze plan, you're going to have probably a lower premium for a bronze plan than you would for a silver or a gold plan. But the bronze plan is going to have higher cost sharing charges, so a higher deductible, higher co-payments, higher out-of-pocket cap compared to especially a gold plan. And commonly, many people are enrolling in silver plans, often because they are able to get cost sharing reductions only with those plans. So many people are kind of in that mid-level silver plan, which has a 70% actuarial value. So the way that actuarial value is actually calculated is that you assume this entire population, we have a little fake population over on the right side of the slide, enrolls in a plan. You estimate the percentage of cost that the plan would pay for that population's covered services, and the calculation is 70% of the cost of covered benefits, then the result is that this is a silver plan that we're looking at. And you can use actuarial value to compare one plan with another plan and how those plans cover the same population. And that's how you kind of get a sense of how generous the plan coverage is. You can see in the red box at the bottom, actuarial value does not represent what the plan will cover for a given individual. So it doesn't mean that a silver plan is going to cover 70% of your costs. That really depends on how much medical care you use and other factors. The actuarial value also doesn't determine what benefits or prescription drugs are covered under the plan, nor does it impact the provider network. So those are important elements of how generous a plan is for a given consumer, for example, that really aren't reflected in the actuarial value. And for your purposes, when you're actually looking at plans on the website, you're going to see that actuarial value just basically is a guide to how insurers set their different costs under their plan, their out-of-pocket costs. Charges to the consumer. So you can see here on this chart, this is just examples from 2015 plans of different types of metal levels and different levels of cost sharing. So you can see, for example, on the far left side that the bronze plan with a 60% AV has a relatively high deductible and out-of-pocket limit compared to the, for example, silver plan, which has a $2,600 deductible. And the gold plan that has a $1,250 deductible. Another important thing to note about this is that, for example, the two bronze plans actually have different cost sharing, even though they have the same actuarial value level. They have different deductible amounts. They have different cost sharing charges for the different services that we have on our chart here. You know, an inpatient hospital visit with one bronze plan doesn't it costs the deductible and then nothing else. And in the other bronze plan, you would pay the deductible and then 25% of an inpatient hospital visit. So it's just an important thing to be aware of. The cost sharing is going to vary from metal level to metal level, but it can also vary quite significantly within a metal level. So it isn't really the only thing people should be looking at. It's sort of a first step in deciding what kind of plans people want to consider. So just an example of how cost sharing works. Let's imagine that this is Jane. I think she's still named Jane. Health Plan Y has a deductible of $5,500, an out-of-pocket limit of $6,350. Inpatient hospital costs 25%, so that's a coinsurance rate. Primary care visit has a $40 copayment, and then there's also 25% coinsurance for specialist visits and generic drugs. You can see here that at the beginning, Jane is paying the full amount before the deductible of $5,500. She's paying 100% at that point. And then once she gets to $5,500, she's going to face a $40 copay, for example, for a primary care visit. Once she reaches the deductible, she's paying 25% in coinsurance for the services that she's using. And then toward the latter part of the year, she's racked up enough costs that eventually she reaches the out-of-pocket limit of $6,350. And then after the point that she's reached the out-of-pocket limit, it's the plan that's covering 100% of her costs. Any services Jane uses beyond that point, she doesn't pay anything out of pocket. And then something to also be aware of is that we've been focusing just up till now on the individual cost sharing amounts under a plan. And it's just something worth noting that for a family, when more than one person is getting enrolled in a plan, the deductible and the out-of-pocket limit can be twice, or usually twice, what the individual amounts are. So in this case, the family that's in Plan X is going to pay $8,000 for their deductible compared to Jane, who's an individual, paying $4,000, and their out-of-pocket limit is also twice what Jane is going to be charged under her plan. As we noted before, each individual member of that family is still protected by the individual out-of-pocket limit. So that's an important protection for each individual, but the plan can charge them up to $13,700 total. Another thing when you're looking at plans for families is that there can be different types of cost sharing when there are more than one person, when there's more than one person on a plan. So one type is embedded family cost sharing, and the other is aggregate family cost sharing. This isn't the kind of thing you're probably gonna. It's not going to be obvious when you're looking at plan documents. It's a question that may be worth asking, particularly if family has a member that has very high health costs, it's worth kind of knowing how the plan will operate. So with an embedded deductible, as you can see at the top of the slide, in addition to the family deductible, if the plan has an embedded deductible, there's smaller individual deductibles that apply to each family member. And then embedded family cost sharing also usually comes with an embedded out-of-pocket limit. So there's that larger family out-of-pocket limit, but then smaller individual out-of-pocket limits that apply to each individual enrolled in the plan. And then with aggregate family cost sharing, you could have an aggregate deductible where all the family members' expenses are pooled toward one combined deductible. And an aggregate out-of-pocket limit where all the family's expenses are pooled toward one combined out-of-pocket limit instead of those embedded individual limits and deductibles. So again, there's always the protection under federal law of the $7,350 in 2018 as the maximum amount that an individual can pay, regardless of whether they're in an individual or family plan, and regardless of how their out-of-pocket limit is set up in their plan. Another important aspect of plan design is in-network versus out-of-network cost sharing. Some plans approach this in different ways. And in some cases, you'll see different charges for in-network cost sharing versus out-of-network cost sharing, much higher charges for out-of-network cost sharing. So you can see that in this chart with Plan A. It's a silver plan, and you can see that there's a different deductible if a person goes out of network. That means they have $10,000 deductible instead of the $5,000 that they would have if they stayed with an in-network provider. And then all the other cost sharing is also higher, including the fact that there's no cap on the amount that they may have to pay out of pocket if they go out of network under that example in Plan A. With Plan B, you can see that's an example of a plan that doesn't provide coverage out of network. So that's an important thing to be aware of too. It may be something you see with marketplace plans, and that makes it really, really important for people to be aware of who is in the network and to stick with those providers. Otherwise, they're not going to get good financial protection from that plan. And then in Plan C, you can see a more complicated type of design. That is a feature with some marketplace plans where there's a tiered network. Tier 1 is sort of the preferred network where people have the lowest cost sharing. In this example, it's $2,000 deductible and a $5,000 out-of-pocket limit, and then like a $20 copay for a primary care visit. If you're going with the preferred providers, the doctors and hospitals that are in the preferred network of the insurer. If you go to Tier 2, you're still covered. You still get kind of mid-range out-of-pocket costs, but higher definitely than if you're going to preferred providers. And then with Tier 3, it's kind of the most cost there. And if you're using those providers, you're paying a lot more out of pocket than you would if you use Tier 1. And this is another example of how this actually works in practice, and it's meant to get at a couple of different issues that people face when they go out of network. Not only the fact that they may have higher cost charges under the cost sharing charges under their plan if they use out of network providers, but also that they could have be experiencing what's called balance billing, which you'll see in this example. So under this plan, there's an in-network deductible of $5,000, an out-of-network deductible of $10,000, as you can see at the top. And then there's a requirement that if you go to a primary care visit, you pay $25 copay if you go in network and 50% co-insurance if you go out of network. So the examples with the purple bars at the bottom are that if you go to an in-network doctor, the doctor, let's say in this example, is charging $200, and the plan's allowed amount, which is the amount that the plan has agreed it will pay, is $100. And then in this case, because it's an in-network doctor, that doctor has agreed to accept the plan's allowed amount as the doctor's full payment. So the plan pays $75 toward that $100 allowed amount, and the patient pays a $25 copay, and that takes care of the whole thing for that patient. And the amount that person has paid, the $25 copay, does count toward their out-of-pocket limit under their plan. If instead the person goes to an out-of-network doctor and that doctor also charges $200 for the visit, the plan allowed amount is still $100, but in this case it's an out-of-network doctor that hasn't agreed to accept the plan's $100 allowed amount. They charge higher. They charge the whole $200. So in this case, the plan is paying 50% of the cost of this visit, which is what the out-of-network cost sharing is that they've agreed to. And then the patient ends up having to pay $150. So that's the remainder of the doctor's bill, since this is an out-of-network doctor that hasn't agreed to the $100 charge that the plan pays. And then the other important thing to note, in addition to paying more toward that doctor's bill, if you go out of network, that out of network does not, that charge that you pay, that $150, doesn't count toward your out-of-pocket maximum. So you're not getting that kind of protection if you end up using a lot of care out of network. Another very important aspect of marketplace coverage for folks is cost sharing reductions, and we're going to talk a little bit about how those work because they obviously impact the cost sharing charges under people's plans. Cost sharing reductions are a federal benefit that reduces the out-of-pocket charges that enrollees pay for medical care covered by the plan. People with income up to 250% of the federal poverty level are eligible for cost sharing reductions, and those are sometimes called CSRs. And then in order to get the reduced cost sharing, eligible people have to enroll in a silver plan through the marketplace. That's the only way that they can get this assistance. There's 3 different levels of CSR plans based on income, and you can see them on the chart here. The first column shows you standard silver plans with a 70% AV. That's what we've been focusing on so far, just regular, not cost sharing reduction plans with a $73.50 out-of-pocket limit. And then you can see that as people's income goes down and they're enrolling in a silver plan, what actually happens is that plan is transformed. It has a lower deductible, lower out-of-pocket cap for them because they have less income to be able to afford the out-of-pocket costs under those plans. So there are, with these different AVs that people are entitled to at different income levels, also there are reduced out-of-pocket limits that they're going to have to pay. And similar to the AV kind of different cost sharing amounts that we saw with non-CSR plans, you do see some variation between kind of the different cost sharing as you go up the income scale or down the income scale. So with this is plan A, this is one plan, silver plan. Without the CSR, you can see that it's a 70% AV plan. It has a $4,500 deductible, a $6,300 out-of-pocket limit, and then a $10, $20 copayment for primary care and specialist visits, and $5 for generic drugs. If a person is enrolling this plan and they have income that qualifies them for cost sharing reductions, then they're actually going to see the plan in the next column with the 73% AV, or they're going to see the plans with 87 or 94% AV, depending upon their income. That could mean a deductible of $750 in the case of a person who's between 151 and 200% of federal poverty level, and lower copayments for the services that they use, and then an even lower deductible and other cost sharing for folks that are under 150% of the poverty level. So this is a comparison of 2 insurers' CSR variations. This is just to show that even within this cost sharing reduction plan world, there are differences in cost sharing that are worth paying attention to. So depending upon what consumers are looking for, they may need to pay attention to those specific charges. The AV alone really isn't enough to tell you for sure what it's going to look like. So on the top row, there's a $250 deductible for plan A and a $100 deductible for plan B. You can see the out-of-pocket limit is very different. It's much higher for plan A than it is for plan B. And then there's different copayment charges for prescription drugs, for primary care visits, specialty drugs in particular after the deductible are $150 in the case of plan A, and then with plan B there's a co-insurance percentage, so 25%. So that's important. Those are important features to pay attention to for folks in CSRs. Another feature with cost sharing provisions is that American Indians and Alaska Natives can be eligible for special protections. So there are There's special assistance for members of, and this is explicitly federally recognized tribes and Alaska Native Claims Settlement Act corporation shareholders. They can enroll in or change marketplace plans each month. And then for people who meet that criteria, who are between 100% of federal poverty and 300% of federal poverty and who qualify for premium tax credits, they can get zero cost sharing plans. So they would pay no deductibles, co-payments, or other cost sharing when using in-network medical care. And some out-of-network care is also available with zero cost sharing. And then for people with incomes below 100% FPL or above 300% FPL, there is a limited cost sharing plan available. Under those plans, the eligible person pays no cost sharing charges to receive services from Indian healthcare providers or from another provider if they are referred to that provider from an Indian healthcare provider. So I will stop there.
All right, thank you, Sarah. And with that, we'll hand it off to Hallie for the second part of this presentation on evaluating plan design. And just a reminder, we will take questions at the end of the presentation. So if you have questions, please drop those in your Q&A box. And with that, I'll hand it off to Hallie.
Perfect. Thank you, Kyle. So as Sarah mentioned, how plans are structured, how they structure their cost sharing can have a really big impact on people based on their health needs. So we're going to take a look at ways to help people evaluate these plans to find something that best meets their needs. So some basic things for people to consider when looking at plans are obviously the monthly premiums. A lot of people want to pay as little as possible per month. So that's always a key thing to look at. You also want to look at the plan design. The cost sharing charges all have a really big impact on how much a person will pay for health services. And it's really important to also look at what services may be exempt from the deductible. You also want to look at visit limits on covered services and other included services. All marketplace plans must cover the same basic benefits, but there are definitely some variations between these plans. You also want to look at prescription drug coverage. Each insurer is going to have different prescription drugs that they cover, and the covered drugs will each be organized in different cost sharing tiers. And so those tiers will determine how much a person may pay when they fill a prescription. And lastly, you want to make sure you look at provider networks. And this can include both the plan's network type and the list of providers that are in network. So how do you find and evaluate all of this information about the plans? Let's look through some of these examples. This is something that I'm sure all of you are very familiar with. It is the Summary of Benefits and Coverage, or an SBC. As a refresher, this is a standardized document that every insurance company must create for virtually every plan that they sell, and this is true both on and off the exchange. The SBC provides details on the specific cost-sharing design of the plan, including the deductible amount, if there's a separate prescription drug deductible, what the out-of-pocket max is, and if the plan provides out-of-network coverage. It's also going to have information on the specific cost sharing for covered services and lists whether the deductible applies or is waived for a service. The SBC is also going to list information on visit limits or exceptions for certain services. Plans are going to differ on these limits a lot, so it's important to note when limits apply if a person is going to need these services. As I mentioned before, plans can offer additional benefits that are not required by the ACA. They can include things like acupuncture, infertility treatment, adult dental benefits, and even coverage of services outside the US. Each plan is going to be really different, so it's just another thing to consider when evaluating a plan. Now turning to prescription drug coverage, we're going to go through an example of looking at prescription drug tiers. There are two main questions that a person may want to know if they're currently taking a medication or any medication. First, does the plan cover their prescription? And if it is covered, what coverage tier is it in? In this example, we have a person who is taking two medications, drug X and drug Y. Drug X normally costs $50 a month if you are uninsured and buy it directly from a pharmacy, while drug Y is much more expensive at $400 a month. Plan A lists drug X as Tier 1, which has a $10 copay. Plan B lists the drug as Tier 2, which has a $40 copay. Drug Y is not covered by Plan A, so the person would have to pay the whole cost out of pocket for this particular drug. Plan B covers the drug at Tier 3, which for this plan means a 40% coinsurance once the person meets a $500 prescription drug deductible. So what does that mean? That means that the person would pay the first $500 of the total expense for that drug and then pay 40% of the remaining cost. Adding those total costs together for both medications for the entire year, in this scenario, the person would actually pay less money if they selected Plan B. However, if Plan A did cover drug Y, it could end up being the cheaper option. So you really have to look at tiers and figure out how much a person would pay based on their medications. Now let's look at provider networks. There are several different types of networks that marketplace plans may have. It's important to note that most areas are not going to have all of these options available, but they're still really important to know. There can be some differences in how these networks may manage care for enrollees, but the main difference that we're going to take note of here is whether or not they include coverage for out-of-network providers. PPO and POS plans do include coverage for out-of-network providers, while HMOs and EPOs do not. However, there is one really important exception, and that is emergency care in an ER. This is something that all marketplace plans must cover, regardless of whether it's in-network or out-of-network. Now, when looking at network types, you also want to look at the different plans' provider networks. These are 3 examples, and we're going to say they're all HMOs, but they have different provider networks. One, Plan A has a very narrow network. Plan B has a much broader network. And Plan C is an integrated model. So that's something like Kaiser, which essentially has all their doctors located in one or a few big medical complexes. The size of the provider network may affect whether or not a person's current doctor is in network or how many options they have if they're looking for a new doctor or a certain type of provider. Narrow networks, it's important to point out, are not necessarily worse coverage. They're just another aspect to look at when you're comparing plans. Now I'm going to go through some scenarios to sort of unpack how people might compare plans based on all these considerations. In these examples, we're going to use plans from 2016 to compare costs. So costs will definitely be different this year, but all of these strategies and all of these key considerations still apply. So to start out, what are some of the key questions you might want to ask a person who's shopping for coverage? You want to know what the person's priorities for health coverage are. What services and healthcare providers does the person expect to use? Does the person want to continue seeing one or more specific doctors or specialists? And are there any medications that the person takes regularly? So to help people compare plans, we put together a marketplace plan comparison worksheet. I'm sure a lot of you have seen this before, but if you haven't, it's a tool we developed for the Beyond the Basics project. You can find this on our website in both English and Spanish, and it can help you compare up to 3 plans side by side. So we're going to use this tool to kind of help us compare plans for these examples. For our first scenario, we have Joe and Danielle. They live in Miami, and their income is $41,000 a year. They're both looking for insurance, and we're going to say they're eligible for a premium tax credit of $198 a month. Their income is a little too high for them to qualify for cost sharing reductions. So this is just the premium tax credit is all that they're eligible for. They're relatively young and healthy, but Joe does have asthma, so that's something we're going to look at. So how can we start helping Joe and Danielle narrow down plan choices? There are a lot of plan options in the Miami area. So when comparing plans, it's important to figure out what some of Joe and Danielle's priorities might be. Do they care about a low monthly premium, a manageable deductible, low copays or coinsurance, or access to primary care pre-deductible? We also want to consider some specific plan details that Joe and Danielle want to look at. So Danielle would like to continue seeing her current doctor. So we're going to see if her doctor is in network. And then because of Joe's asthma, we want to look to see if his current prescription inhaler is in network and covered by these plans. And he also is interested in looking at how many specialists are in network. So let's pick 3 plans that are available to Joe and Danielle. One is a cheaper bronze plan that also happens to include adult dental benefits. One is a mid-priced silver plan, and one is a gold plan. As you can see, the out-of-pocket maxes for these plans are relatively close, but the deductibles vary quite a lot. In option 1, the plan has a deductible and out-of-pocket max that are the same. This means that for every service subject to the deductible, Joe and Danielle are going to need to pay the full cost of services until they hit that $13,000 amount. After that, because they've hit their out-of-pocket max, all in-network services will be paid for by that insurer. Note that the plan does cover generic drug prescriptions pre-deductible, but that is the only service exempt from the deductible in this plan. Option 2 has a much higher premium, but a much lower deductible. And the plan does cover a lot of services such as doctor's visits or ER, and an ER stay, and they cover that pre-deductible. Now, option 3 has the highest premium, but it has the lowest deductible, and it has even lower cost-sharing charges than the other 2 plans. So now we're going to look to see if Joe and Danielle's current doctor is in network. We're going to use the worksheet to write down Danielle's current doctor, and then healthcare.gov allows you to search for a specific doctor when you're comparing plans. The look of this tool has definitely changed in the last year, but you can still search for a doctor using this plan finder tool in healthcare.gov. And you can also check the provider directory on the insurer's website to find out this information. There's usually a link to the directory on healthcare.gov or in the summary of benefits and coverage for each plan. You can also contact an insurer directly, and that's how you'll get the most accurate information. So, in this example, we can see that Danielle's doctor is in network in the Molina and the Blue Cross health plans. So we include that on the worksheet. And again, it's important to note that if this doctor is really important to Danielle, it might be a good idea to actually call the insurer or the doctor to double check that the doctor is definitely in network. Just because there can be mistakes or old information on some of these tools, so it's always a good idea to check if this is something that's really important to a person. So now let's look at coverage of Joe's asthma medicine. We can again use this search function on the Plan Compare tool in healthcare.gov to check for a prescription. And in this example, we're saying that only Ambetter covers Joe's particular inhaler. Now, if you want to know a little more, you can check each plan's drug formulary or preferred drug list to see what tier a prescription drug is covered under. In this case, because 2 of the plans that we're looking at don't actually cover Joe's prescription, you may want to look at what other asthma medications are covered under these plans and at what tier. And then finally for this scenario, we're going to look at how many respiratory specialists are in network and accepting new patients. You can check each plan's provider directory to search for how many specialists are in network in a specific area. Each insurer is going to have a different way of doing this, but they should all have provider directories that you can search through. As you can see, Option 2 has the broadest network of specialists in the particular area that Joe and Danielle live. Now, as we look at these 3 plans, we can see that none of them have everything Joe and Danielle are looking for. They'll have to decide which priorities are the most important to them when they choose a plan. Plan 1 has a cheaper monthly premium, includes dental benefits, and has Joe's prescription in network, but it has a really high deductible and covers almost no costs before that amount. Plan 2 has a more manageable deductible and Danielle's doctor in network, but the monthly premium is more expensive and Joe's current asthma inhaler is not covered. Plan 3 has the most generous cost sharing, but the premium is nearly $500 a month. So Joe and Danielle are going to need to decide what is the best plan that meets their healthcare needs and their financial needs. So now we're going to move on to our second example. This is Doug. He lives in Cheyenne, Wyoming, and makes $22,000 a year. He's eligible for a premium tax credit of $463 a month and is eligible for cost-sharing reductions since his income is below 250% of the poverty line. Doug has diabetes, so we want to carefully weigh his plan options to see which plan will help him effectively manage his condition. So how can we help Doug compare plans? First, it's important to note that in this example, we're saying Wyoming only has one insurance carrier offering coverage through the marketplace. There are definitely places where this is the case, and there's probably going to be a lot more in this coming open enrollment. But very importantly, this doesn't mean that all the plan options are the same for people shopping in these areas. In Doug's case, he is going to want to carefully look at the cost-sharing variations available to him in each plan. Because he's eligible for cost-sharing reductions, which in his case are equivalent to a plan with an 87% actuarial value, we're going to just look at silver plans for this example. Also, since only one carrier offers coverage, we are going to take a look at if any of the available plans cover out-of-network services. That way, if Doug has a particular doctor or specialist that he wants to see and that provider is only covered out-of-network, he could be able to see that provider and have some of the cost covered by that plan. However, with that said, with income this low, it's going to be really important for him to try to avoid the out-of-network costs because cost-sharing reductions do not apply to those out-of-network costs. So now let's take a look at some of the plans that are available to Doug. Here are 3 silver plans. They're all available through Blue Cross Blue Shield. Although they're all the same cost-sharing reduction level, the actual cost sharing is really different in each plan. As we've mentioned before, only one carrier offers coverage through the marketplace in this example, so all the plan options here actually have the same provider network and the same drug formulary. That means that premiums and cost sharing charges are the elements that we're going to really focus on for Doug. So with that in mind, let's take a look at different cost sharing for Doug's diabetes, medication, and supplies. Doug currently has a prescription for insulin, as well as various supplies to maintain his diabetes. Let's look at his insulin prescription first. That is covered at Tier 3. Even though the drug formulary is the same for each plan, the actual cost sharing for each tier is different in each plan. So for example, Plan 1, Tier 3 has a 20% coinsurance once Doug pays a separate $150 drug deductible. But Plan 3, which also has a 20% coinsurance, has that cost sharing kicking in after Doug pays a general deductible of $200. So that means that any other out-of-pocket costs beyond prescription drugs will count towards that deductible amount. Now let's look at the coverage tiers of different supplies to maintain his diabetes. Glucose blood test strips are covered at Tier 2. For Plan 2, Doug would pay $25 per prescription without having to meet any deductible. For Plan 1, he would pay $25 after he met a $150 drug deductible. So that's a lot of information. To help us get a sense of what the cumulative costs for each of these plans might look like, let's look at the comparison of each plan's summary of benefits and coverage. They have an example of cost sharing for routine maintenance of type 2 diabetes. These sample scenarios are available in all SBCs, and they show how a plan might cover medical care in given situations. In this case, Plan 2 appears to have the lowest cost sharing for managing type 2 diabetes using the assumptions in this example. This is definitely not a perfect tool to figure out actual costs for a consumer, but it can be used as a kind of a general guide to get a sense of how much financial protection a sample patient might get if they are covered under different plans, and especially if they're managing the same type of diabetes. So now let's move on to how many specialists are in network for Doug. Once again, there's only one carrier, so we're going to be looking at the same provider network for all of these plans. In this case, we find out that there are actually 0 specialists within 50 miles of Doug. We broaden the search further and find that there are only 2 in-network endocrinologists in Wyoming who are currently taking new patients. So this may affect how Doug assesses out-of-network coverage for these plans. All 3 of these plans are PPOs, and so they cover out-of-network services. Here is the summary of some of the cost sharing for out-of-network services. It's important to point out, which we've talked about before, that cost sharing, out-of-network cost sharing, does not count towards the general deductible or towards that out-of-pocket max for a plan. Some plans like these have a separate deductible and a separate out-of-pocket max for out-of-network benefits. Also, a person getting cost sharing reductions should be aware that they generally don't apply to out-of-network cost sharing amounts. So out-of-network costs would be the same for a low-income person as they would be for a person not getting cost-sharing reductions. Also, people should know that for the out-of-network services, you may be charged that additional amount for services. That's called balance billing, which Sarah talked about. So that's something that's really important to keep in mind when you're looking at these out-of-network costs. Now, let's move on to our last example. This is Jason, Michelle, Andre, and Sasha. They live in Houston, Texas, and make $50,000 a year. When they apply for health coverage, they find that Andre and Sasha are eligible for the Children's Health Insurance Program, and that Jason and Michelle are eligible for marketplace coverage with a tax credit of $233 a month and cost sharing reductions. Jason and Michelle are really interested in looking at how different plans affect their out-of-pocket costs. So in this example, we're going to show how different cost-sharing designs work when you use your coverage. So for this example, we're going to use Jason and Michelle's general healthcare health expenditures from last year as a base point to compare costs. First, they both went to their primary doctor last year for a total of 7 visits. We're going to say that a full cost of 1 visit is $100. Second, Jason hurt his back a year ago, so he sees an orthopedic specialist for that. We're going to say that last year he went 4 times. Third, prescriptions. We're going to say that Jason has a monthly prescription for his back pain that is $150 a month at full cost. And lastly, we're going to say that Michelle had to visit the ER last year, so she had an ER visit, emergency room visit. Now let's look at some plans and see how the cost-sharing designs affect Jason and Michelle's out-of-pocket costs if they use the same amount of healthcare as they did last year. So for this example, we're going to look at a cheap bronze plan, which has a pretty high deductible and doesn't cover any services pre-deductible. And we're also going to look at a silver plan. Remember, Jason and Michelle are eligible for cost sharing reductions at that 73% actuarial value. This is the lowest level of cost sharing reduction help. A standard silver plan is 70% actuarial value. But there is that added help with cost sharing, so it's still a good idea to look at options for silver plans. In this particular plan, they have a much lower deductible than the bronze plan, and it also covers most services pre-deductible. So let's look at the breakdown of out-of-pocket costs for each health plan based on Jason and Michelle's health needs from last year. For Plan A, none of the costs of the services are covered by the plan before Jason and Michelle hit their deductible. So they end up paying the full cost for the doctor visits, the specialist visits, and the ER visit. The plan does have a separate drug deductible of $400, so they do hit that amount, and then they only need to pay a copay for the remaining months of that prescription. We're going to say that the prescription for Jason is in tier 2 for both of these examples, just to kind of simplify things. Now, for Plan B, all of the services are exempt from the deductible, so Jason and Michelle pay a fixed copay amount for each of the services that they use during the year. With this breakdown of healthcare costs, even though Plan B's premium is much more expensive, the annual out-of-pocket costs actually end up being much lower with Plan B. But now let's change up the example. Let's take out the specialist visits and the ER visit from our expected healthcare needs. If we do that, we see that Plan A ends up having slightly less in annual out-of-pocket costs than Plan B. So what this tells us is that out-of-pocket costs can vary greatly depending on healthcare utilization. Jason and Michelle have to think about how much healthcare they plan to use, how much they are willing to pay in monthly premiums, and ultimately weigh the cost of premiums versus cost sharing. Every person is going to have really different priorities for health coverage, so it's important to try to help them figure out what the most important priorities are to them when they're shopping for plans, so that they have a plan that best fits their needs, depending on what is most important to them. So with that, I think we're going to take some questions. So I'll pass it back to Kyle.
Yeah, thank you, Hallie. We have a few minutes for questions here. So we'll start with one for you, Sarah. What happens if the current administration does not pay for cost sharing reductions to insurers? And if so, when would this go into effect?
Yeah, so we don't really know what the administration is going to do in that regard. I think the important thing for people to remember heading into open enrollment is that consumers are still entitled to receive the cost sharing reduction plans that we were just talking about, and insurers are still obligated to provide those plans. So basically, if you're working with folks that live in a place where a marketplace plan is available, they are still going to be able to get those CSR plans. In many states, there have been plans kind of laid in the rate filing process for insurance, where the premiums will rise in order to account for the loss of CSR payments to insurance plans. If that happens, the people who get premium tax credits will be shielded from that increase because their subsidies will also rise. So I think from the consumer's perspective, the most important thing is not to panic and to proceed as usual, even though it's a really, really unusual situation. Those subsidies are still, those plans are still there for people. They're still entitled to get that assistance. And honestly, we don't really know what might happen. What we do know is this is still the law, and people are still able to get this help.
Thanks. And could you explain the difference between the family deductible and the individual deductible?
Yeah, so it's just a feature that if you have more than one person signing up on a plan together because they're members of the same family, the plan itself will have larger amounts for annual cost sharing charges. So annual cost sharing charges are like the annual deductible that applies for the whole year, and the annual out-of-pocket cap or annual out-of-pocket maximum that applies for the whole year. For an individual, if I think our example, it was like a $4,000 deductible for an individual, but then if there's a family, there's an $8,000 deductible. And what that means is that, let's say the $8,000 deductible applies to most services under the plan. So basically, the family will have to have that much spent out of pocket if the deductible applies to everything. If that's if that's the aggregate deductible that we talked about. It's actually a little bit more complicated because there can be different ways that the family costs add up. But basically, if you're looking at plans and you have more than one person signing up for a plan as a family, they will have a plan that perhaps has a larger deductible amount. Then it's just worth knowing if there are individual deductibles within that, the embedded deductibles that we talked about, for example. But basically, it's just because there's more people on the plan, and the plan is allowed to still meet the same actuarial value and have higher charges for family members. So that's just the way that the plan is going to look. If the people in that family enrolled in separate plans, they would each have individual cost sharing amounts under those plans.
For the next question, could you explain what tier means and where that information is located?
I'm assuming the question is about the tiered networks?
I think so, yeah.
So that's the kind of information that you would see either in the summary of benefits and coverage or the other plan marketing documents, but basically they may not call it a tier necessarily. That's the term that we chose to use. Not all plans would use that term. They might say things like preferred provider list and that sort of thing to talk about which network of providers under their plan has the lowest cost sharing associated with it.
All right, so thank you all for these presentations today. Just a couple of words in closing. As a reminder, we will be distributing the materials from today's session via an email, and we will post everything to our Beyond the Basics website at healthreformbeyondthebasics.org. Please note that the webinar video will not be available on our website until the conclusion of this four-part series. Part 4 is scheduled for this Thursday, September 28th at 2 p.m. Eastern, and will explain who can qualify for an exemption from the individual shared responsibility payment, and we'll cover how to calculate the penalty for people who don't maintain health coverage or qualify for an exemption. You can register for that webinar and all of our other upcoming webinars on the Beyond the Basics website under upcoming webinars. All of the materials for our Beyond the Basics project are posted to this website, including reference charts, guides, frequently asked questions, and key facts. And if you have any questions or need any assistance going forward, please email our Beyond the Basics contact email at beyondthebasics@cbpp.org. And with that, we'll bring this week's webinar to a close. Thank you again for joining us today.